Good evening. On the behalf of Delhi Spine Society, we welcome you to our Master Series lecture classes, the second in a row. After overwhelming support and enthusiasm of our fellows, our PGs and our colleagues from Allied Department, having more than 1,000 views in the last one, we are now coming up with the second one on lumbar canal stenosis. And I had a great news. I just spoke to Professor Park, and we are happy for our Korean Spine Society members also joining us for today, apart from Bangladesh, Nepal, who are regular in such programs. So this is a dedicated 90-minute talk on single pathology, and the convener for today's meeting is our dear friend, a senior member of Delhi Spine Society and senior consultant and unit head at the Indian Spinal Injury Center, Dr. Ankur Nanda, who will now introduce you his faculty. Welcome, Ankur.
Thank you, Dr. Rupinder. Thanks for the kind welcome. So I welcome you all to this exciting webinar on lumbar canal stenosis. So we have tried to keep it very simple, very comprehensive, so that we can understand all the intricacies involved. And we know that, lumbar canal stenosis is bread and butter for a spine aspiring surgeon. And we have tried to, cover everything from, where the nerves get compressed, which are the hidden recesses, to what causes these symptoms to come, and what are the principles of management, and what do you do when you get stuck in a complicated scenario where there are multi-level problems. And also then we have an excellent video by Dr. Puneet where he is going to show you how exactly to decompress and get good results. And at the same time we will be joined by our guest faculty from all the way from Chennai, Dr. Bala, who's going to sort of explain to you, if you end up in the dreaded complication of a dural tear, how to manage it, how to get out of it. So you have everything from basics to complications. So without much ado, I think with permission of the chair and the president and also the secretary, Dr. Mahapatra, shall we go and invite the first speaker, Dr.
Yes,
Anuj?
Ankur, please go ahead. Please go
Sure,
ahead.
sir. So Dr. Anuj Mundra, yeah, Guru, you were saying something?
No. Let you invite by while he shares the screen. I'll just share something. Yeah.
Sure. So our first speaker is Dr. Anuj Mundra. He is a young dynamic surgeon who's working in Action Balaji Hospital in Delhi, and he's going to be, taking you through the various recesses, triangles, and zones associated with lumbar canal stenosis. So Anuj, please share your slides while I hand over the mic to Guru.
Hi. So welcome all. So we will have question answer sessions end of all the talks because we are not going to take questions after each talk. Because whatever questions you have, the questions might be answered in talks which are going to be delivered after each talk. So you have a chat box. You can type your questions there. So we'll take each one of your questions at the end of the session. Thank you. So Anuj, you can take over.
Good evening, everyone. Thank you, DSS organizing team, for having me here. Surgical anatomy of the lumbar canal. So, historically, decompression is one of the first spinal surgeries to be performed, and it is also the most common spinal surgery now being performed. So, to break a prison, you must memorize its map very well, and therefore, similarly, to navigate body's vulnerabilities, you need to know the anatomy. Knowing pathomechanics is like knowing the internal working of the prison, which will be discussed in the subsequent talk. So, touching some of the basics, such as the lumbar nerve roots that travel below the corresponding pedicle, as opposed to the cervical nerve roots that travel above. And MRI is something that needs to be studied very well before going into the surgery. You must analyze the bony architecture, the situation of the disc, ligamentum flavum, and the dural sac. You have the vertebral body in front and you have the posterior arc at the back. These are the muscles that surround the vertebral body, and the vertebrae, they articulate at the two facet joints and the intervertebral discs. So you need to preserve the facet joints when going in for just a simple decompression. So when viewed from posterior, you have the spinous process in the center and the laminae on either side, the superior and inferior articular process, as well as the transverse process on either side. The shape of the spinal canal can be either round or ovoid, or trefoil. And trefoil allows for a very small cross-sectional area. It is present in 15% of the individuals, and it predisposes to lateral recess stenosis. The vertebral body, the canal's boundaries are anteriorly vertebral body, disc, and posterior longitudinal ligament. Laterally, you have the pedicles and the neural foramen, depending on the sagittal level, and the facet joints, lamina, and ligamentum flavum at the back. So the compression can be either in the central canal, it can be in the lateral canal or the lateral recess, or it can be in the foraminal region only. So you need to inspect the facet joints, the osteophytes on the superior articular process, which is the more lateral structure. It can lead to narrowing of the lateral recess and compression over here, whereas osteophytes on the inferior articular process, which is a more medial structure, it can lead to central canal narrowing. Degeneration, it predisposes to anterolisthesis because it changes the orientation of facet joints to sagittal. And if the facet joint orientation is greater than 58 degrees or around 60 degrees, then there is a high predisposition to anterolisthesis. So narrowing of the spinal canal due to bony dysplasia is known as congenital stenosis. These patients have fewer degenerative changes. There is a multi-level involvement, and commonly these patients are young adults. Moving on to disc, not every bulge is a herniation, and you can, if it is herniated, it can be a protrusion, extrusion, or a sequestration or migration of the disc. But in aged individuals with lumbar canal stenosis, you will either have a symmetric or asymmetric disc bulging, and this disc bulge classically increases with axial loading and in standing position. Based on the MRI, the herniation can be either central, subarticular, foraminal, or extraforaminal. This is an example of a central herniation, the subarticular herniation in which the nerve gets pinched between the disc and the facet joint, and the foraminal disc and the extraforaminal disc herniation. These cause the compression of the exiting nerve root, whereas the lateral recess and the central canal, they lead to compression of the traversing nerve root. So at the level of L4-5, the exiting root will be L4, which is uncommonly compressed. It's mostly the degenerative stenosis, and the L5 is the most commonly affected nerve root. At the L5-S1, you have commonly lytic listhesis, foraminal stenosis, and this compresses the exiting nerve root, which is the L5. So herniation that migrates above or below the end plate, regardless of the fact whether it's an extruded or sequestered disc or not, it is a migrated disc herniation. And several classifications, whether it's a high grade or low grade or the zone of migration, have been described, but practical utility when you go inside for a surgery is whether it is at a pedicle level, it is superior to pedicle or below the pedicle. That needs to be gauged from the MRI, and an exposure of the lamina corresponding to that has to be made. The ligamentum flavum, it links the ventral section of the adjoining vertebral laminae. It limits hyperflexion. So it has two layers. One is the superficial and one is the deep. The superficial is removed easily because it has a shorter attachment and a more superficial attachment. Whereas the deeper layer, it has an attachment below the lower lamina or the caudal lamina. Often extraction of this attachment without either burying out the lower lamina can lead to inadvertent dural tears. So a lot of care has to be taken while removing the lower lower attachment of the deeper layer. So when we look at the MRI, and you should analyze what structures are compressing anatomically and where all the compressions are there. So in this case, you have the central canal compression because of the osteophytes. You also have the lateral canal compression. And with the imagination, what the post-op MRI of the patient would look like, the decompression should be approached. Like removal of only the ligamentum flavum in the central portion may give a picture intraoperatively of a decompression and good appearance of dura. But when the patient actually loads, there can be a potential lateral recess stenosis. There can be, due to remaining osteophytes and due to remaining ligamentum flavum, there can be persistent compression. Similarly, while decompressing, one must be able to visualize the shoulder of the nerve root and be able to remove the facet joints adequately. So this all, the width of the facet joint should be assessed in the MRI, and so as to not sacrifice the facet joint and around 1/3 of the facet joint you can preserve. You can sacrifice actually. 1/3 you can sacrifice, and 2/3 you can preserve to allow for adequate decompression. So while looking at the MRI, again, a facet cyst may be present, and intraoperatively, it is suggestive of a facet joint dysfunction, and which can be leading to instability, which can be assessed on X-rays, and a decision making can be made accordingly. The nerve root positioning is such that the dorsally and the caudal nerve roots are placed dorsally. So in this way, if there is a dural tear, you would be aware which rootlets may potentially be coming out. Normally, rootlets coming out in a dural tear, that does not translate into a neurological deficit. And neural foramen, it has a lot of microvasculature along with the exiting nerve root, and this microvasculature can lead to epidural bleed. So there can be a radicular vein, there can be intervertebral veins. Along with that, the neural foramen also has the ligamentum flavum, which serves as a guide during transforaminal endoscopy. One must be aware of lumbar nerve root anomalies, and a high degree of suspicion is needed so as to not sacrifice any nerve in these cases. These are not present very commonly. In 14 to 17% of cadaveric studies, there have been these lumbar nerve root anomalies, and 2 to 5% of individuals in clinical investigations with MRI have been found to have these anomalies. So they have been divided into 3 classes. Class 1 has 2 roots exiting from the common sheath, and one is at acute angle if it is type A, and 90° of type B. Class 2 has 2 roots which exit through the same foramen, and class 3 has an anastomosing branch connecting the 2 roots. So this anastomosing branch, it crosses into the disc space and is susceptible to injury during discectomy. Conjoined roots are normally less mobile than the normal roots, and they may be separated accidentally or damaged by excessive tension. L5-S1 levels are the most prevalent region for the conjoined roots. Also, there may be forking of the nerve root after exiting from the dural sac. The empty zone is located caudal to the yellow ligament attachment. It is below the nerve root, and it functions as a portal for the lateral recess while approaching from the transforaminal region to decompress the lateral recess, or going through the superior articular trans-SAP approach. The Cambin's triangle, again, for transforaminal endoscopy, is a very vital region. The exiting nerve root serves as the hypotenuse, the superior border of the lower vertebral body as the base, and the superior articular process at the back, along with the caudal vertebra as the height. So this triangle is the key triangle to go approach for a transforaminal discectomy. And this is how the transforaminal discectomy, this triangle is utilized. Then there is a concept of a safe triangle, which is important for transforaminal epidural injections. And as opposed to the Cambin's triangle, which goes below the nerve root, the safe triangle is above the nerve root, and it carries high chances of vascular injury, high chances of nerve root irritation while performing the block.
Dr. Anuj, can
Yes,
we
sir. Yes,
finish?
sir. Summing up. Yes, sir. So while looking at the anatomical structures in MRI, one must not forget that there can be intradural issues which can be potential cause of the pathology. Take-home messages: knowledge of anatomy helps in proper interpretation of radiology, surgical identification of structures. Since you have to decompress the room from a window, which can be either from posterior, it can be just a interlaminar window, or a window from the side, you need to know for sure what you are seeing from which window. Thank you.
Thanks Anuj. It was a great talk, and it was very well explained, all the anatomical recesses and structures. We had initially planned to sort of go from here, from this normal surgical anatomy, into pathomechanics and clinical radiological correlation. However, the next speaker, Dr. Tarun, he's himself dealing with some medical issue as of now. So he will be shortly joining. So what I'm going to do is I'm going to sort of skip to the next speaker. That's Dr. Gururaj himself. And he's going to be talking on principles of management and surgical options in lumbar canal stenosis. And I think by that time, Tarun will also be able to join, and we'll take his lecture at that time. So Guru, if you can share your slides and, do your presentation. Guru, you're muted.
Can you hear me and see my screen?
So we can hear you, and your screen has just started to come up. Yes, but we can't see your slides yet. Yeah, okay.
Can you see now?
Yes, we are good to go now.
Okay. Good evening, all. So basically, we had planned this by step, but unfortunately, we have to skip Dr. Tarun's talk. My talk will be overview of lumbar canal stenosis and simple basics of lumbar canal stenosis, how you diagnose, how you approach, and what simple surgeries you can actually offer to these patients. So we just heard from Dr. Anuj that what is lumbar canal stenosis, and what we need to concentrate is these three things: what gets narrowed, why does it gets narrowed, and what is the effect on the neural structures of this narrowing of the spinal canal. So if we answer these questions, we will be able to arrive at a plan or a particularly a tailor-made treatment for a particular patient. So we just heard there is a central or a primary or a congenital stenosis, and with the secondary canal stenosis, which gets narrowed because of the degeneration, is lateral recess or a acquired stenosis. So we just skip these slides. So we'll just come to this. Why does the canal gets narrowed? Who are the culprits? The culprits are facet joints, instability, and a listhesis. Listhesis can be a stable listhesis or a unstable listhesis. So these are mainly which cause lumbar canal stenosis and cause problems. So what are the clinical presentations? So the chief complaint in these patients is long-standing back pain. Usually it starts with the back pain, and then slowly the back pain can reduce or back pain continues to worsen, and then they start having bilateral leg symptoms. Like, main thing is they start with having a claudication. Sometimes they can have radiculopathy. Then they start showing numbness, heaviness, tiredness, and the last thing is a weakness they develop. Sometimes they can suddenly present with directly with the weakness. And sphincter or sexual dysfunction or a bowel bladder involvement is very common. If you don't poke them and ask them directly questions related to bowel bladder issues, you won't be able to diagnose them, because they are a very subtle symptoms they have. But then if they present you with a frank quad syndrome, that will be too late for intervention in lumbar canal stenosis. Clinical findings: the same kind of stenosis, the same amount of stenosis, the same MRI, the same age group, but patients can have a variable sensory motor symptoms and deficits. So basically, the key to diagnose these patients and to identify the deficits is to make them walk to the distance where they start getting tired, and then examine them. That is when you actually exactly examine them, what they are experiencing practically. So you first thing is, lumbar canal stenosis or a neurological claudication can mimic a lot of things, or a lot of things can mimic neurological claudications. So first thing is, you should know what is neurological claudication. That is, they can present with pain, they can present with cramps, they can present with heaviness or numbness in the legs on walking. These symptoms are distance specific. Usually in neurological claudication, the distance gradually goes on reducing. The person who is experiencing the symptoms at 500 meters 6 months ago can experience the same symptoms at 200 meters as the days progress. Region in the leg is usually specific, especially when it is associated with the radiculopathy, and relieved on stooping or sitting is a classical symptom of lumbar canal stenosis, that is neurologic claudication. You have to distinguish between basically a vascular claudication and neurological claudication, because it's very easy to confuse both and treat a vascular claudication as a neurological claudication and have complications. So what are the differences? So in neurological claudication, it is a dermatomal distribution. Leg pain constant on flat surfaces, slopes, and stairs. So it doesn't differ. There can be hypo or paresthesias associated in neurological vascular claudication also. When the stenosis becomes severe, you can have paresthesias too in vascular claudication, and can walk the claudication distance after each sitting and stooping break. And the distance of walking gradually goes on reducing in neurological claudication. But what happens in vascular claudication? It's a non-dermatomal pattern, usually in glow and stalking distribution. If you examine pulses, pulses are not felt. It relieves only by standing. It doesn't require patient to stoop or sit, can't walk or a cycle, and it's usually fixed distances. It doesn't goes on progressively reducing, and you can see trophic changes in the skin changes in these patients, like shiny skin, hair loss, and maybe you can find a tropical ulcers also. So if you have a long standing claudicant pain, but then suddenly patients start having a rest pain or a radiculopathy, then what should you suspect? That is lumbar canal stenosis, where there is a fresh disc, which you can see here in this picture. Or you can have a facet cyst, which is appeared and which is causing a radiculopathy. So whenever you have a radiculopathy, newly onset radiculopathy in a long-standing claudication, so you have to suspect and reinvestigate. If you have an old MRI, you need to repeat the MRI and look for these pathologies. If significant back pain is associated with LCS, what should you look for? That is LCS and osteoporotic fractures. Basically, because these patients are old, elderly age group, so osteoporosis is very common in these patients. So you can have a osteoporotic compression fractures in these patients. So you need to have this in mind and reinvestigate them. Bladder disturbance, especially when it comes to male patients, they can have prostate issues. So rule out pre-existent urinary outflow problems by doing maybe USG KUB and by a uroflowmetry. There can be subtle variation in the leg pain symptoms which LCS patients present. That is, they can present directly with the imbalance in walking. They can present with the rest pain, numbness without pain. They can have radiculopathy without true claudication and catastrophic neurological deficits. They can present with sudden foot drops. So when a straightforward LCS presents to you, don't think it is just a straightforward LCS. Look for osteoarthritis of the knees and wasting and tremors, because again these are elderly age group patients, and they can have predominantly knee symptoms rather than having a claudicant symptoms. Check for pulsation, check for reflexes to rule out upper motor neuron signs, to rule out tandem stenosis, and check for neurology. Ask always bladder symptoms, leg symptoms at rest, and discuss exactly for which problem, for what problem, for whether they have come to you for back pain, whether they have come to you for your leg symptoms, whether they have come to you for their bladder bowel symptoms. Exactly discuss with them for what they are presenting to you. Other etiologies which stimulate LCS, you have to again rule out. In every LCS patient, you have to examine for hip and sacroiliac joint pathology. And non-degenerative spinal pathologies can mimic like infection, tumors, especially like schwannoma and neurofibromas, and fractures, that is osteoporotic fractures, which are very common in this age group. Coexistent confounding factors, because these things will definitely make your life miserable if you operate on these patients. If you don't know these patients have pre-existing these problems and you have not discussed with them, like central nervous system disorders, Parkinson's is very common in these patients, extrapyramidal syndromes again very common, and peripheral neuropathy, because most of these patients are elderly, they are associated with diabetes. So diabetic peripheral neuropathy is very, very common. So how to suspect whether they have a peripheral neuropathy? That is, if the numbness is out of proportion to their radiological features, and if they have symptoms only in glow and stalking areas, be suspicious in, especially in diabetics. It might not change your surgical indications, because surgical indications are totally not related to the peripheral neuropathy symptoms, but the expectations and the results and the satisfaction after surgery definitely changes. That is what ultimately we are aiming for in these lumbar canal stenosis surgery. Documentation can be done for peripheral neuropathy whenever you have any suspicion by doing EMG and NCV. This is again very much discussed in all the conferences. So because most of the times it is coexistent, that is lumbar canal stenosis and osteoarthritis knee, and the other thing is having a upper motor neuron signs in these patients, that is tandem stenosis. So in every lumbar canal stenosis patient, you have to examine for the upper limbs, look for Hoffman signs and reflexes. Plantars can be mute because of the tandem stenosis, because they have a lumbar canal stenosis. So you have to ask for upper limb symptoms. You have to look for Hoffman signs. You have to look for exaggerated reflexes in the upper limb. So, and then if you have to differentiate basically imbalance because of lumbar canal stenosis and the basic cervical spine. So you have to ask whether the imbalance started first or the pain started first. So if the imbalance, usually the cervical spine patients start with the imbalance and then they start having the uh, uh, tingling, numbness, and more weakness in the lower limbs in cervical spine patients. Coming to management, role of surgical treatment. This is the usual dictum, that is only 20% of them worsen, 20% usually improve with your conservative treatment, and 60% usually remain unchanged. Indications for decompression, that is a symptomatic stenosis which is not responding to your conservative treatment, which is progressive, which is disabling, which is not allowing them for doing their activities of daily living. Leg symptoms are more than back pain, including the deficits, and there has to be a clinico-radiological match when you offer surgery for these patients. Otherwise, you will further investigate them. What surgery? Surgical treatment for this is simple. LCS is surgical treatment is, what you do is medial laminectomy plus nerve root decompression. For nerve root decompression, what you need to do is a medial facetectomy, because that is where most of the stenosis exists. That is where the most of the symptoms are due to lateral recess canal stenosis. So you have to see this Christmas tree appearance when you do a decompression. The dictum is, in lumbar canal stenosis, when you do just a decompression without fusion, you shouldn't add on discectomies to these decompressions unless you have a fresh onset of radiculopathy and you have a lateralized acute disc herniation. The discs which are hard and central bumps should not be touched. It will cause more instability in these patients. What you should do is,
Guru, sorry to interject. Can we
stop.
run through a little bit?
Yeah. We'll finish in a minute. So
Yeah.
what you have to do is mainly a wide decompression with facet, medial facetectomy. But what you have to remember is to preserve the pars. So how it looks actually, if you do just a laminectomy, this looks like that, and then your lateral recesses are still not decompressed. Then when you do a medial facetectomy, see, your lateral recesses get decompressed here. So this is the aim of ultimately a decompressive surgery in a lumbar canal stenosis. And facet alignment and lumbar canal stenosis surgery, it ultimately decides whether you are going to fuse proactively in these patients or you are just going to do a decompression. So in a sagittally oriented facets, the facets like Dr. Anuj was already mentioning, the facets which have sagittally oriented, there is a high preponderance that actually this buttressing effect of this facet goes away, and then they slip. So that is why you need to whenever you have a sagittally oriented facets, you need to just do a just do have to fixation along with the decompression. So this is the example. When a sagittally oriented facet, you do a medial facetectomy, ultimately it slips. So in a coronally oriented facets, you do a decompression, it still has a buttressing effect. So ultimately, when you do decompressions, you have to see these shoulder of the nerve root which is exiting into the foramen. So that is how it should look. And pars intraarticularis, you have to preserve. See here, it is excessively excised, and then ultimately it leads on to a iatrogenic listhesis. So this will just keep. Last take home messages: always look for confounding factors like medical neuropathies, CNS problems, and coexistent cervical myelopathy. Always look for specific causes of acute exacerbations like a disc. Clinical instability has to be taken into note. Dorsalis pedis pulsation is mandatory. Associated medical neuropathies like diabetic neuropathy, associated cord compression higher up. Always try to treat which is more predominant, whether LCS or a ONE. So I'll just skip this. Take home message: you always have to remove what you have to remove, even if you have to fix. Ultimately, the aim of surgery in LCS is decompression, and a wide decompression, you have to do it. So if you do a good LCS surgery, the results are highly gratifying. Thank you. So
Thanks,
I
Guru. Thanks for a comprehensive talk on, principles of fusion. And I think you have covered a lot of important things. Also, what you have covered is how to recognize which ones to operate, how to differentiate them from different pathologies. So I think that's nicely covered. And I'm happy to say that Dr. Tarun is now here with us. And so we are going to go back to the second lecture, which was on pathomechanics of lumbar canal stenosis and clinico-radiological correlation. So Dr. Tarun, over to you, and you can start sharing your slides.
Thank you very much, Dr. Ankur. Apologies for joining late.
So Tarun, just because you have just joined, we'll be taking the questions at the end after all the talks are finished, because many of the questions may be overlapping with talks. So we had thought that we'll have a proper Q&A at the end. So yeah. Okay, please, over to you. You can share your slides, please. Also, Tarun, in the meantime, you can unmute yourself.
Yeah, I hope the screen is visible.
Yes, you can put it on slideshow. Yeah.
So I'll be speaking on the basic pathomechanics of how lumbar canal stenosis actually develops. And uh, uh, I think the most important concept regarding the pathophysiology of lumbar canal stenosis was described by Riccardi and Willis, and it is best understood by understanding and imagining the vertebral unit as a tripod, in which the intervertebral discs acts like the anterior support and the biggest stabilizer between the two vertebral bodies, and the two posterior stabilizers are in the form of the facet joints. So, with aging and because of many other factors which are complexly understood, this cascade starts with the degeneration of the intervertebral disc, which leads to disc height, development of tears in the various layers on the intervertebral disc, and this in turn leads to the stage of dysfunction, in which not just the disc but the facet joints also start getting loaded unevenly, and hence the degeneration of the facet joint starts. They develop capsular laxity. Some kind of micro instability develops, which in turn puts load on the already degenerated disc. So this kind of vicious cycle develops, in which all three components of these tripod, they start degenerating simultaneously. With further degeneration and lack of holding capacity of the disc and the facet joints, the stage of frank instability develops, which leads to clinical manifestations of instability pain, which I think Dr. Gururaj has discussed in his talk. And with instability, the foramen, intervertebral foramen, neural foramen also starts collapsing, and this leads to a dynamic compression of the nerve root in the intervertebral foramen, and hence starts the radicular pain and claudication-like symptoms. With further degeneration, the stage of stabilization sets in which the hypertrophic calcification of various structures, such as ligamentum flavum, the superior articular process, it starts, and as osteophytes start forming, which leads to further encroachment of the spinal canal and the foramen by these structures, and it leads to a much severe stenosis. So this point we've already discussed. So this is how the pathomorphology looks like. The central canal stenosis is dominantly caused by the prolapse of the intervertebral disc from front and hypertrophy and calcification of the ligamentum flavum from behind. On the other hand, the foramen is encroached by the foraminal or the far lateral discs, the encroachment of the foramen by the hypertrophic superior articular process, and lateral part of the ligamentum flavum. When these structures start encroaching on the limited space in the spinal canal, the epidural veins also start getting dilated, and they cause a kind of dynamic compression of the spinal canal, which gets exacerbated on activities like walking and standing. So this is a cadaveric section which beautifully shows how the nerve root gets pinched between the hypertrophic superior articular process. So you can see the NR is a nerve root which is getting compressed by the LF, which is the part of the ligamentum flavum in the foramen, and the O is the osteophyte because of the hypertrophy of the superior articular facet. Just behind that is the facet joint. So it beautifully shows how the nerve root is getting compressed by the disc osteophyte complex from the front, a superior articular process osteophyte from the back, and the hypertrophic ligamentum flavum, leaving very little space for its functioning. An axial section also in this cadaveric section shows that how the central canal stenosis develops by hypertrophy of the ligamentum flavum. And you can see all the cauda equina nerve roots labeled as CE clumped together and living in a very tight space, along with the hypertrophy of the facet joints on both sides and a disc prolapse from anterior aspect. The pathophysiology of the claudication pain, which is a dynamic pain, it develops because of congestion of epidural venous blood vessels and increased vascular pressure. And this congestion increases when the patient walks or stands. The cauda equina nerve roots, they gain metabolic energy from blood circulation, or from these small arteries, and because of the diffusion of the cerebrospinal fluid. When the stenosis develops, the CSF flow is highly obstructed, and on walking, the space is further compromised because of the congestion of the epidural veins, and then that is why the patients develop claudication pains on walking or standing. When the stenosis reaches a critical level, then because of chronic stenosis, central sensitization of the pain perceptors that occurs, which leads to chronic rest pain as well in severe and advanced cases. So as it was discussed in the previous talk, the diagnosis of lumbar canal stenosis is clinical and radiological both. So I believe clinical aspects have been touched in the other talk, so I will be quickly skipping them. But in terms of radiological aspects which are important, the MRI remains the imaging modality of choice to diagnose lumbar canal stenosis. And the most commonly used classification is called as a Shiza's classification, which describes lumbar canal stenosis in 4 grades. The grade 1 is no or minor stenosis, in which the nerve roots are clearly visible in the thecal sac, and CSF is also very well visualized. In grade B, which is moderate stenosis, the rootlets are seen, but the CSF is not very well appreciated. In grade C, the CSF is not at all visualized, the nerve roots are clumped, but posterior epidural fat, a thin area of triangular fat, hyperintense zone, and in the posterior epidural space is yet visualized. And in grade D, which is the most severe stenosis, there is not even a visualization of the posterior epidural fat. So this classification is very easy to understand, and it is very easy to make anybody understand by mentioning what grade of Shiza's classification are we actually dealing with. Another important parameters to look in the MRI are the status of the ligamentum flavum, facet joint hypertrophy or facet tropism, how much the canal is compromised. You have to look at any presence of facet joint or synovial cysts. And it's very important to look into foraminal cuts as well, which are the parasaddle cuts. And in that, we have to look how much is the perineural fat obliterated, which denotes foraminal stenosis. Apart from the MRI, X-rays, they have their importance because you have to document any presence of any instability, such as degenerative spondylolisthesis. And dynamic X-rays further help us to understand what kind of instability are we dealing with, whether there is any presence of degenerative scoliosis, or we are dealing with a congenital narrow spinal canal, which may be highlighted by a very small pedicle size as compared to vertebral body width. So as I told you, dynamic X-rays are important to document not just the translational, but also the angular instability, because it is the angular instability or the local lordosis, which is much more important from biomechanical point of view. So in flexion extension views, we not just have to document how much translational is occurring in the flexion views, but also understand how much is it reversible, how much is its reducibility, and how much is the kyphosis getting reduced on putting the patient into extension. It's also important that there are some cases which have degenerative scoliosis associated with lumbar canal stenosis, and in those cases, the sagittal images or the parasagittal images may not be able to give a true picture because of the scoliotic deformity. We may not be able to capture all the representative images in a single frame. So in these cases, we have to rely much more on the axial images to understand what is the anatomy, the rotation, and how the central and the foraminal areas are getting compromised by various structures. So, with this, it is important to understand what kind of pathophysiological mechanisms are acting in a case of lumbar canal stenosis, and we have to understand what anatomical structures are causing the compression individually in each case, so that they can be specifically addressed when we are surgically operating them, and patient can be given a better outcome. Thank you.
Thank you, Dr. Tarun, for a comprehensive talk. We'll take questions at the end of the session. So we have a next talk by Dr. Ankur Nanda, who is Associate Director at Indian Spinal Injury Center in the Department of Spine Surgery. I invite Dr. Ankur to give his talk on decision making in multi-level lumbar canal stenosis. Basically, we are all confused when they present with multi-level stenosis, whether to operate all the levels or whether to just treat single level. Over to you, Dr. Ankur, to clear that confusion. Thank you.
Yeah,
We
I'm
could
just
see your
sharing.
screen. Already it was visible.
Yeah, okay. Is it okay now?
It's fine. It's
Yeah,
fine.
okay. So, thanks, Guru. Thanks for inviting me. And so, as we know, lumbar canal stenosis at a single level for a spine surgeon is quite, I would say, it's quite attractive. And, we are very happy to do these surgeries because we know that when we operate these patients, the results are usually excellent if we have done the right surgery for the right patient. However, this whole, happiness changes into a little bit of a problem when you have cases like these where the problem is, almost everywhere. When you get these old 60-year-old, 70-year-old patients who have changes everywhere, and you sort of keep wondering, where exactly the problem is and how much should I do and how much should I not do. So we'll try to demystify this. So let's try to understand what's so different about this multi-level, lumbar canal stenosis than a single level lumbar canal stenosis. And just to sort of outline a few issues, the first and foremost is, I think, a clinico-radiological correlation. Because, when you do an MRI for a 75-year-old, you are going to see degenerative disc disease, maybe all throughout the spine. And you may not be sure about, what is really symptomatic and what is not symptomatic. Also, most of these multi-level LCSs will either be associated with instability or listhesis or scoliosis or a sagittal imbalance. So again, in a multi-level LCS, these factors start confusing your mind. Thirdly, implant fixation and how much to instrument is again a challenge, because usually these patients are elderly and have a lot of osteoporosis, and then the additional problems of osteoporosis and implant loosening is always a problem. And last but not the least, and probably I think the most important, it's an elderly population. The medical morbidities are there. Patients are usually diabetic, hypertensive, or maybe post PTCA, post CABG, or maybe somebody is having a pacemaker. And all this complicates, because what happens is these surgeries are becoming more and more complicated, and your patient is becoming more and more unfit, unlike a single level LCS. And all these factors are playing on your mind, and at the end of the day you are supposed to sort of deliver results to this patient. So I think this is what the problem with multi-level LCS is. Now if you look at the clinical situation of these patients, we see that majority of them will present with neurogenic claudication, and unfortunately many of them have non-dermatomal distribution and paresthesias and numbness, so it's difficult to basically identify which level is giving problem. However, in scenarios where patients have a proximal motor deficit, so by proximal motor deficit, I mean if let's say a patient has a quadriceps weakness, or if a patient has a hip flexor weakness, then it's a clear-cut sign that this problem is not only getting affected from the usual L4-5, but also probably a L2, L3 level for hip flexors, and an L3, L4 level for a quadriceps weakness is getting involved. So you immediately start looking at the upper part of the lumbar spine more carefully when you get a proximal deficit. However, if you just have radicular pains, and dermatomal pain can sort of sometimes can give you a idea. So let's say if a patient has a pain which is going down the buttock and thigh and lateral calf, then we immediately know that it's an L5 dermatome pain. Or let's say if a patient has a pain which is coming to the front of thigh and traveling to the anterior shin rather than lateral calf, then we know that it's the L4 pain. However, vast majority of them will have a buttock pain and a posterior thigh pain, and all around the calf, and this is where the confusion starts. And probably this is where root blocks before attempting any surgery will help, because when you want to identify which level is really giving problem, you can first give a root block and see if the pain goes away. So let's say you have a multi-level stenosis and you are sure that L4-5 needs to be done, but you're not sure about an L3-4 lateral recess stenosis. What you can do is you can give a block in the lateral recess and see if that relieves the dermatomal pain pattern or not, and that will give you an idea, right? To some extent, EMG NCVs can help, but it's really controversial, because majority of the times when we do NCVs, 80% of the times the report will be motor and sensory polyradiculopathy, and that makes no sense. So in such a scenario, I think relying on NCV may not be a great idea. Dr. Tarun just talked about this Shiza's grading, and this study was done by Konstantin Shizas, where he had sort of looked at various types of morphology of dural sac, and he had tried to identify which ones will require surgery and which ones will not. So this is a great paper which was published in JBJS, which looked at different Shiza grades, and they made a questionnaire, and they questioned a number of experienced surgeons, and they asked them whether they would be operating, which grades would they be operating. And what they came up was that usually grade A and grade B, which means whichever stenosis where CSF is visible either clearly or minimal visibility of CSF, is something which uh, yeah. Are my slides visible?
Yes, Ankur, it's
Yeah,
visible.
yeah. Okay, sure. So these are the so these are the grade A's, and B's are the ones which usually will not require surgery. However, grade C and grade D, these are the ones which will require C. How do you identify grade C? Is whenever the CSF is not visible at all and all you see is fat. So whenever you have multi-level stenosis and you're thinking which one to operate, probably, to some extent, Shiza's grading can help. Again, there are some studies which, to decide whether a patient, when he presents, requires a fixation or a single level decompression can be enough. So we know that, majority of these lumbar canal stenosis patients will be stooping forward. And because of this stoop, sometimes you may be confused thinking that since they are stooped forward, maybe they will require a fixation to correct the kyphosis. But we have to understand that a vast majority of these patients have actually a functional kyphosis and not a structural kyphosis, which means that if you decompress them well and the pressure on the nerves are gone, they are likely to get very straight, or get their normal lumbar lordosis in the post-op period without doing fixations. So in this paper, what they saw was that at least 50% of the patients had sagittal imbalance before surgery, and only a single, only decompression surgery basically corrected sagittal imbalance in 74% of the patients. Which patients would require a fixation or correction? What are the risk factors? Whenever there is a, whenever there is a listhesis, or whenever there is a huge difference between the lumbar lordosis and the pelvic incidence of the patient. So we know that the pelvic incidence is the angle between the bicoxofemoral axis and a 90-degree line drawn between the S1. So whenever the pelvic incidence is high and lumbar lordosis is low, these are the patients who are likely to have post-operative sagittal imbalance. Again, this paper looked at what were the results of the patients when they had stenosis associated with degenerative listhesis, and what should be done in these cases when patients have stenosis along with listhesis. And this study looked at these patients, and they found that the patients who were associated spinal stenosis and degenerative listhesis, when they were treated surgically, they had greater pain relief and improvement in function after 4 years than non-operative treatment. So usually in a lumbar canal stenosis, whether when you want to decide which ones to operate, which ones not to operate, and whether to operate or not, probably surgery with a listhesis is better. This paper had looked at, does multi-level lumbar stenosis lead to poorer outcomes as compared to single level stenosis? And the studies have also shown that usually a degenerative stenosis and single level degenerative stenosis with single level stenosis do better surgically as compared to multi-level stenosis. A word about sagittal oriented facets. I think Guru had covered it well. In your decision making, when you are doing this multi-level stenosis, which one to decompress and which one to fuse, the orientation of the facets make a huge difference. And like in this case, wherein the facets were absolutely vertical, whereas there was severe stenosis as well. So a fixation probably in these cases is better, as explained by Dr. Gururaj also. Again, a number of patients now come with lumbar spinal stenosis with scoliosis or maybe with kyphosis. And here the pathogenesis of stenosis is quite different. Pathogenesis of pain is quite different, and it is very important to understand what really happens in a degen scoliosis, and that will help you in deciding whether you want to correct the deformity or you just want to simply decompress. So if you look at this, what are the unique biomechanical characteristics? There is loss of lumbar lordosis, there is increase of apical rotation, and there is a lateral vertebral slip. The cause of pain in degenerative scoliosis is usually either pedicular kinking, wherein the root is kinked and stretched by downward pedicle migration on the concave side. What this means is, we know that the nerve root passes under the pedicle. Whenever there is a scoliosis, the vertebra will tilt, and moment it tilts, the nerve passing under this will come under pressure and stretch, and this is called as pedicular kinking. So that is one phenomena which happens in degenerative scoliosis, and which will not be visible as a compression on the MRIs. Then foraminal and extraforaminal disc herniations are also, which are very common in the concave side of the curve. And then the double crush syndrome specifically, in which the same nerve root is compressed at both the lateral recess and the foraminal zone. And I'll just show you some MRIs to actually explain what I'm saying. So if you see these figures, this is this patient had a right L3-4 radiculopathy and left-sided degenerative scoliosis. And on myelography, if you see, there is no remarkable, let's say, compressive factor on L3 and L4 roots. But if you look at the radiculograms on the right, L3 and L4, they reveal compression and elongation of the nerve root because of the pedicular kinking. So that is what the pedicular kinking usually happens on the concave side of the spine. Incidence of root affection in degenerative scoliosis is usually maximum root involved is L4, which is 68%, followed by L5. And in so many cases, L3 and L4 can be involved together. The site of affection for L3 and L4 roots is usually foraminal or extraforaminal on concave side. And we'll see in the quickly in the next slide what I'm talking about. And L5 and S1 are usually in the lateral recess tenus on the convex side. So let's look at this scoliosis. So if you can see, this is a degenerative scoliosis, and you can see that there is a olesthesis along with the apical rotation. Now look at this. This is a left-sided convexity scoliosis, and you can see on the right side, the foraminal L5 area is quite clear. However, if you look at the L3 and L4 foramens, they are compromised. So basically on the concave side, it's not the L5 or S1 which will get compressed. It's usually the L3 and L4. Whereas on the left side, if you see, the L3, L4 is quite open, whereas the left L5 has got completely compressed because of the secondary curve on the lower side. So this is how a degenerative scoliosis behaves, and you can identify your roots where you want to decompress. A word about osteoporosis as well. When we do these multi-level
Dr. Ankur?
fixations. Yeah, I'm
Can we
finishing in a minute. Yeah. So, I think we'll skip these slides. So in short, what you need to do is whenever you are dealing with multi-level stenosis, you also need to take care of the osteoporosis part. Now I'll just show a couple of cases to sort of orient you towards how to treat these multi-level stenosis. So this is a patient with the multi-level stenosis at L3, 4, L4, 5 level. And also you can see lateral recesses are stenosed at L5, S1. And these are this patient had no back pain, only radiculopathy. And so what we did here was a multi-level laminoforaminotomy, wherein we have spared the midline. There was no instability on the flexion extension x-rays. There was no listhesis. And this is why a laminoforaminotomy was done at multiple levels. However, if you look at this case, she is a 58-year-old female, bilateral lower limb radiating pain and back pain also now, and progressive walking distance is reducing. And what you can see here is that there is a listhesis at L3-4 with an angular instability, and multi-level stenosis, severe stenosis at 3-4, moderate at 4-5, and 5S1 bilateral lateral stenosis is there. So, and these are the CTs wherein you can see that there is ossification of the ligamentum flavum also at the level of L3-4. So what we have done is a fusion at 3-4, but decompressions at 4-5 and 5S1. I think I'll skip to the last case and then finish with that. So this is another patient. Now this is the other extreme of the spectrum where there is severe back pain and inability to move, and patient had a spine surgery previously in 1998 for leg pain. And now the patient has come with this type of X-ray wherein there is a scoliosis, where there is a gross lumbar kyphosis. And you can see that all the L3-4 is completely listhesed. There is a vacuum sign at the L5-S1. You can see multi-level stenosis happening at the central areas as well and foraminal areas as well. And when you see these patients, that you'll need to go full hog here. And what we have done here is a long level fixation up to D10 and gone up to S1 and done a multi-level TLEF. So so in short, whenever you are doing multi-level stenosis, it's not only about that nerve decompression has to be done, but you have to take so many factors in mind, which include structural deformities to the health of the patient. Thank you.
Thank you, Dr. Ankur. I invite the next speaker, Dr. Puneet Giridhar, who is the head spine surgery at BLK Max Hospital, Delhi, and he will be showing us a video of lumbar canal stenosis decompression. Welcome, Dr. Puneet.
Thank you, Dr. Guru. First of all, let me ask, am I audible?
Yes, Dr. Puneet.
Okay, thank you so much. I think a great initiative by the Spine Society Delhi chapter for starting this masterclass series, and I feel privileged to be presenting a minimal invasive decompression for lumbar canal stenosis. So, as the name suggests, ULBD, it's a unilateral laminotomy and a bilateral decompression of spinal canal. And just a few slides I'll take you through before I show the video. The whole idea is to perform a thorough decompression, as Dr. Gururaj has already narrated well in his talk, the need for doing bilateral recess decompression and decompressing the traversing nerve roots in a lumbar canal stenosis. And the only difference here is that it is being done through a unilateral incision on one side of the midline. So the purpose is to increase the spinal canal area without compromising the facet joints, and at the same time maintaining the midline structures as well as the paraspinal preventing paraspinal muscular disruption. This entire procedure can be performed through an open technique also, a bilateral decompression, but then it will not be a minimal invasive, and it will not be through the unilateral approach. It will rather be through a midline laminectomy. But a unilateral decompression over the top can be performed even if it is not MIS, if it is performed without the tube. So, as you can see, a standard laminectomy post-op CT would look something like this, where a bilateral decompression is visible through the midline, while here a post-op CT shows the midline being intact because there's only a single side laminotomy. And however, a bilateral decompression is performed for the patient who has bilateral symptoms and severe claudication. So the various indications and contraindications for an MIS decompression in lumbar canal stenosis. The foremost indication is obviously neurogenic claudication due to LCS, and also radiculopathy due to lateral recess stenosis, unilateral or bilateral. A facet joint cyst with central canal stenosis can also be addressed with a tubular approach for decompression. However, the contraindications need to be kept in mind, which is a prior surgery at the index level, which may require a bilateral decompression and wide exposure, and to avoid the midline scar. And a stenosis in the exit zone and far lateral area can also be very difficult to access through a tubular decompression. However, the newer endoscopic approaches like full endoscopy,
we can't see your slides.
The slides are not visible.
You will put slides later, but
you have to share your screen, Puneet.
Screen.
Is it visible now?
No.
Puneet, it's not visible. I think so.
One
Actually,
sec.
we thought that you were going to speak first and then, but then they haven't
One
been
sec.
visible for some time. Yeah.
Okay.
I
Now?
think, Puneet, your screen is
Now?
not shared at all.
Yeah,
Is
yeah.
it visible?
Now it's okay.
Yes, it's
Yeah.
there. So just go on
Sorry,
slideshow.
we didn't notice that.
Okay. So the contraindications are prior surgery at the index level, which may require a bilateral decompression, as an over-the-top MIS decompression is difficult if there is a previous laminectomy being performed, and a stenosis in the exit zone or a far lateral zone is very difficult to access through the tubular MIS approach. Another contraindication is the congenital stenosis, which may be a deterrent due to short pedicles. So in the step one of doing an MIS decompression for lumbar canal stenosis, the incision is made around 1 to 2 centimeter from the midline. Depending upon if the patient is bulkier, one may choose 2 or up to 2.5, but usually 1.5 centimeter is the standard incision from the midline. And the usual tubes which are used are around 18 millimeter. So we take a 2 centimeter incision so that there is no muscle ischemia or stretching at the corners. So the various steps, the first step is to lock the tube with the serial dilators and attach it to the flexi arm. The second step is to use a high-speed burr to do the bone removal. That's an ipsilateral laminotomy as well as burring under the base of the spinous process to the contralateral lamina so that the ligamentum flavum is visible on both sides. The third step is to undercut the spinous process, the base of the spinous process. And the fourth one is to identify the superior aspect of the ligamentum flavum attachment as we do in any microscopic MIS discectomy. And then the fifth step is the lateral recess decompression on the ipsilateral side from which we have done the access. And then the last step is to decompress the contralateral side of the canal and to mobilize the traversing nerve root. So the case which I am going to show is a 75-year-old male. He's a doctor himself. Severe claudication. Claudication distance is markedly reduced, and he had a stenosis and with radiculopathy on the right side. And there is a severe stenosis which is visible on the axial section on MRI. The flavum is markedly thickened, more on the right side than the left side. And the sagittal section also shows a single level lumbar canal stenosis. So the x-rays didn't show any frank instability. Neither patient had any significant back pain. He also had a previous fracture at D12, but he didn't have any pain and didn't have any history of trauma. And neither was he osteoporotic. So I mean, it's kind of difficult, maybe pathological, we don't know as of now, but patient didn't have any pain and didn't come for that. So first of all, we marked our incision. Sorry, these X-ray pictures are representative pictures of another patient because I couldn't find the same picture for the same patient. So getting in your initial dilator through the 1.5 centimeter from the midline incision, we get our serial dilators and the tube in place. And usually the last dilator, if it is 5 centimeter in depth, then you use a tube which is 1 centimeter more than that, because as you go deeper or over the top, you might have to insert the tube in deeper during the surgery. So you don't want your tube to go inside in the skin to come overlap it. So once you have locked it in place, let me share my video. One moment, I'm finding it a little. Is it? Inside. Okay, one moment, I think I'm finding it difficult to get the video on. Just one moment, I'm getting the video on.
Guru,
Can you see the screen now?
Puneet, your screen is not visible.
Screen is not.
Puneet, can you just, I think, open the video and share the video out of the presentation?
Mm, I am sharing the video now. Um, yeah, here.
No,
Wait. That's the one. That's the one. Yeah. Is it visible? No, one
Yes.
sec. Yeah.
Yes, Puneet.
Okay,
Now
great.
it's visible.
Thank you. Yeah. Am I audible now?
Yes, Puneet, you are audible and the video is working.
Okay. Sorry about the delay. So it's just the first step here is that we have docked our tube at the spinolaminar junction, and we are using the cautery to just denude the lower end of the upper lamina and the base of the spinous process. So that's the first step, like we do in a microdiscectomy procedure. The only difference is that in microdiscectomy, you can be closer to the midline. If you have to do a lot of work over the top here, it's better to give your incision half a centimeter away from the midline if one is intending to do the over the top decompression here. So the next step is like any other disc procedure is to get the bar on the inferior part of the superior lamina and thin it out. Here,
Puneet, can you orient us to the medial lateral?
Yeah, this is the cranial part. Can you see my arrow here?
Yes.
On the left side of the screen is the cranial, and on the top is the medial.
Okay.
The bottom is the lateral, where the surgeon is standing on the left side of the patient.
Okay.
And the right side is the caudal.
Okay, got it.
So the cranial is left and the caudal is right. So we are on the left side of the patient, and we are using a high-speed bar now to actually build the spinolaminar junction now and go under the spinous process to visualize the midline. So if there is some bit of hemostasis issue, one can use a bone wax, or you can continue to bar, and that will provide you further hemostasis if it is not that challenging. So the most important part here is to identify the base of the spinous process and bar it, undercut it.
You are using the cutting bar?
We use the cutting bar always, but if you have any doubt, one can use a diamond bar also. And from there on, once you have the thinned lamina, then you can use your regular Carrison cutting 2 mm or 3 mm depending upon the space. Initially, I use a 2 mm and then move on to 3 mm once you have adequate space, and go all along till the ligamentum flavum attachment. At the same time, a part of the medial facet is also being knocked off with the same Carrison. Since he is a 75-year-old and the bones are not that strong, but on his DEXA he was okay, but that may be part of it is because of the degenerative element. So the tube is already inclined a lot medially, and since we have already gone across the midline here, you will see the entire ligamentum flavum being exposed. So the next step is to take off the ligamentum flavum from the proximal attachment. Either you can use a small curette, or I do it with a dissector itself, like in this case. And then I use a small Carrison to peel off the, like a number 2 Carrison or a number 1 Carrison, to peel off the ligamentum flavum from either side. And that will immediately give us a wide exposure of the canal on both sides. Since we have already tilted the table to the other side, and there is already an undercutting happened on the base of the spinous process to the opposite lamina. So you will see the entire thecal sac being exposed on both sides immediately after this. So as we have done on the proximal aspect, so I use a reverse Kerrison to knock off a millimeter of the distal lamina so that the ligamentum flavum attachment comes off there. So here I have taken off the inferior lamina and you can see the fat is very well visible. And following that, what I do is I tilt the table back to my side and now I ensure an adequate decompression of the ipsilateral lateral recess and mobilization of the nerve root on your side. And in case, like few cases have associated disc herniation, and sometimes that is the reason that patient comes in and opts for the surgery is because of acute on chronic symptoms where patient has a disc. I have actually edited that part. This patient had an element of disc was visible on MRI also, which came popping out from with the proximal migration in this case of the disc. So we have removed the part of the SAP. If you see here, we removed with the Kerrison the part of the supraarticular process, the medial aspect, so that this nerve root is clearly visible going into the lower foramen. And one can use a ball tip or a hook to assess it for the final assessment. So the inferior lamina and the middle border of the supraarticular process is being taken down to ensure that this recess is adequately decompressed. So following that, one can tilt the table back to the opposite side. So it is always advisable to do your bony work before you knock off the ligamentum flavum. Do your bony work below the spinous process on the contralateral side because the ligamentum flavum acts as your safety barrier. But in case of decompressing the opposite root, I always remove the entire flavum and decompress the ipsilateral recess properly so that it is very easy to retract the dura to your side when you are doing the work over the top on the other side for the neural elements. So now since there is a lot of space on our side, it is very easy to access the opposite recess and actually retract the contralateral traversing nerve root. We can also use a ball tip to assess the contralateral recess properly. This is the contralateral traversing nerve root visible, which can be retracted and one can see the disc there. So it is very tough through this approach to do the work on the contralateral exiting foramen. That is something I think endoscopes are better at addressing those issues. So thank you so much. I'll be happy to take the questions.
Thanks, Puneet. It was an interesting video and very clearly demonstrated. So we'll be taking questions at the end of the session. We have one more important talk which is still there, and Dr. Bala has already shared his slides, so no delay in that. So he'll be sort of taking us through the dreaded complication of dural tear. We always feel more scared, but whenever I've seen Bala talk on it, he makes it sound really simple and he makes it feel as if it's not a big deal. So let's try to learn from Bala, how to deal with this complication and how to get out of it. So over to you, Bala. Thanks for being there. You are muted, Bala. You can unmute yourself. Yeah.
Sure. Thanks, Ankur. Thanks, Guru, and thanks to the Delhi Spine Society for inviting me. First of all, as Ankur said rightly, a lot of young surgeons, especially from orthopedic background in the initial years, they're very scared of one big complication, which is a dural tear. And I'm just here to break that myth and say that if you don't get enough dural tears, that means you've not done enough spine surgery. And if you don't know how to repair dural tears, you should not be a spine surgeon. So I think, those both go handy. Dural tears generally happen because of many reasons. But we all been seeing, lovely presentations about, how Spinal stenosis can be very challenging in diagnosing, in treating. At the same time, if you look at the pathology, it's a multifocal pathology. You have thickened ligaments, thickened facet joints, synovial cyst, calcified ligament, short pedicle, abnormal pathology. So all of these things put together is why you get a spinal stenosis. And the very clear message was, however stenotic, whatever the pathology is, a good adequate decompression is essential. Only then the patient will have good relief. If you do an inadequate decompression, either things will worsen or the patient will have no relief whatsoever. So the decompression either is a midline or is unilateral through the tube, as very nicely demonstrated by Dr. Puneet. And also, you most likely have to do a medial facetectomy. You have to remove a lot of bone. So you might either use a burr or you might use an osteotome or something to release the facet joints. And also, if you look at the dural anatomy, there are many ligaments which many people don't realize. If you do lumbar spine surgery, you will realize that there are lots of ligaments that run across the dura, and they're usually attached to bone or they directly attach to the ligamentum flavum itself. So these are, the two important ones are the Tollard's ligament and Hoffman's ligament. And if you're not aware, if you're not wary of these ligaments, then you will definitely end up doing a dural tear, because if you catch this ligament with your upcutter and if you just pull it, the whole ligament which is attached lower down will cause a dural tear and it will end up with more problems. So the two dreaded instruments that really cause them are the upcutters, your Kerrison rongeurs, or your burr or an osteotome. Very rarely is your disc forceps or anything which I normally don't use in those places. So the ligamentum flavum, which is attached from the superior end of the upper lamina to the lower, and the attachment have to be very, very careful when you use your upcutter. And that's one place where you get a dural tear. Second is sometimes if you're not careful with your drill, which is rarer, can also happen. And when you're doing a facetectomy, you can catch the edge of your root or a little kinked dura, and the dura is usually very kinked because of the severe stenosis and the thin dura in elderly patients. So these are the things when you get. There are also lots of adhesions. You can get de novo adhesions, ligaments. When you have a bony compression with a synovial cyst or a calcified ligament, there is a very severe adhesions. And especially if you have a degenerative scoliosis, the concavity part of it has severe stenosis. The dangerous instruments, as I said, are your upcutters, your disc punch, and your drill. So these are the three most common instruments which cause this. So why do people worry about dural tear? I mean, dural tear is a dural tear. You can just repair your dural tear, or if sometimes it's very small, you can just leave it and usually it stops. But the complications that can happen, very rare, however, are a persisting leak which can cause infection, pseudomeningocele, a fistula, a meningitis, arachnoiditis, epidural abscess, leading to meningitis, brain abscess. So, as a neurosurgeon, I've seen a lot of these complications because we open the dura as well for tumors and other pathologies. But with the 25 years of experience, I can tell you that dural tears rarely cause any of these major complications. You probably might get one or two in your career if you're not very careful and don't follow some of the principles I'm going to explain to you. So you either get an expected or a not so expected tear. The expected inadvertent tears are usually in elderly people. The more tighter the canal, the more chance. So you need to be more careful, take more time. Don't, push through your surgeries. Take a lot of time, especially in elderly people. Thick ligaments, if you identify on your scan, there's thick. And if you can also see if there's any calcification, it's reported, then be more careful with them. Severe lateral recess stenosis, because if you have to decompress your lateral recess to get rid of the radicular pain, and when you do that in a tight stenosis, again, you can have hypertrophied facets, large kissing facets, where you have to do a medial facetectomy, calcified ligament. If somebody has, repeated epidural injections, these people tend to have more adhesions and you need to be very careful. Or if you can see any abnormal anatomy like a short pedicle in achondroplastics or degen. Primary is usually around 2 to 3%. It's reported up to 13%. Revisions are much higher. And the primary repair gives you the best result. So if you find a dural tear and if you think you can put even one single stitch, go ahead and do it. Do not take chances, because only when you take chances, the secondary repair, the next time you go in, it becomes more difficult. Sometimes I've very rarely seen, you do a good decompression, you adequately decompress the cord, but then finally you end up having a CSF leak a week later, and you wonder why, because everything went very well. If you leave a small bony spike, or if you didn't recognize properly, you're doubtful whether this is saline wash or whether it's a CSF leak, you don't wait enough, and then you just come out, or you have a small tear where you think the arachnoid is intact, and when the patient wakes up and there's a big cough, it just opens up. So these are sometimes very rarely. So identifying a CSF leak is very, very important, the first step. So usually it happens in the second to seventh post-op day. So usually before the patient goes home, most of them leak, or within the first week. If your CSF is kind of mixed with blood in the drain, or if the patient is suddenly having a bout of cough, patient has a history of asthma, allergy, and is coughing a lot and has a CSF leak, or if your wound, you just do a dressing and you push and there is a gush of CSF. Now the question comes about, what do you do? So we look at it in two different ways. One is a CSF leak if you get on table when you're doing the surgery. And the next one is somebody who has a CSF leak after you had a surgery. You either done a repair, or you've not done a repair, or you put tissue and you've come out and then you get a CSF leak. So the remote wound healing, the principles of CSF leak management is to prevent wound healing. So, and to avoid all the complications we discussed. And the next thing is, a patient comes with an expectation of going home in 2-3 days, and then you tell him that, oh, I have to take you back to theater. There's a fluid leak. It increased the cost, unhappy patient, and it escalates, everything else. So the options are, one, you can do CSF diversion. You can contain the CSF so that the wound heals. You can avoid CSF column pressure, or you can re-explore and repair, or you can do all of the above. So you may need to do a combination of many of these things. So how do you do a CSF diversion? So if you have a patient who has a leak, say 2-3 days later, and you know that you've done a very good closure, you don't think you can do a better closure than what you have done, then you go for a lumbar drain. You don't need to put a lumbar drain primarily. If you've done a good repair, or if it is a tiny repair and you put CSF and tissue and you don't think you can repair it, then use a lumbar drain as a secondary option. And the lumbar drain helps with healing the wound. You can keep it for up to 7 days. Very rarely you can go for an external ventricular drain, but I wouldn't recommend that. Most patients get better with a lumbar drain, but minimum of 5 to 7 days. Next is, how do you contain the CSF leak? If there is a small point after putting a lumbar drain, there is a leak, you can put a stitch. You can put pressure dressings. And the lumbar drain should also be tied properly, because it can leak from side of the lumbar drain. How do you avoid CSF pressure? We're going to talk about some of these controversies here. One is bed rest. So many people think that, if you have a CSF leak, you put them in bed for about 1 week and they will be fine. Actually, it does not help. So what I would suggest is to restrict strenuous activity, give them rest, but also make them mobile. So how long do you keep them on bed rest? Well, you can just keep them on bed rest for about a week with reduced activity. But there is no evidence that bed rest stops CSF leak. Positioning. Some people put them in a prone position, and head down for about 5 days. I tell you, that's really torture. The patients will not like it, and they will not want to sleep in a prone position for 1 week. So again, there is no evidence. If you have a cervical wound, you can ask the patient to sit up, because the CSF column and the gravity, the CSF does not leak, it keeps circulating. Lumbar drain, head in, head down, no evidence. So really, it doesn't matter what position they are, as long as they're lying and taking rest, avoiding strenuous activity. Antibiotics, I do not put them on excessive antibiotics. My normal protocol is 1 dose in surgery and 2 doses post-op, and you can stop with that. There is no protocol, there's no evidence that continuing antibiotics till the CSF leaks has any evidence. Antiemetics, however, has an evidence, because if your patient is coughing and sneezing and is straining for stools, then probably they're going to have a CSF leak. So you can put them on laxatives and make sure that they're given suppositories or enema if they are having constipation. CSF inhibitors like acetazolamide, again, Large doses are required for long periods of time to reduce CSF. So we use this in congenital hydrocephalus in pediatric patients. So a short duration of 5 days of acetazolamide is actually only for your satisfaction, for you think you have a good night's sleep, so that you put the patient on acetazolamide to take care. It actually doesn't. So there's no evidence and there's no need to put on acetazolamide if you're thinking about CSF leak. We use this in more cranial cases for other reasons. So really, bed rest and antiemetics and laxatives are probably the only things that you need to take care of, rather than trying to do anything else. Re-exploration and repair. When do you re-explore? When do you repair? So to re-explore is if you failed any of these for 2-3 days, you're still leaking, the lumbar drain is there, the stitch is there, patient's in bed rest, still leaking, go ahead, open it. Intraoperative findings, you are suspected that you didn't do a good repair, or you're not confident, you're not happy, go ahead. So already the patient has developed some headaches. Patient's got severe, hypotensive episodes from headaches, or you have a gut feeling that okay, something's not right. Go ahead and re-explore. What will you explore? You can either go for the same opening. If you're done through a tube, you can go back through a tube, or you just open up and make it an open surgery. Be prepared for unexpected things. You might find a new dural tear which you've not seen. Get a senior person. If you're an orthopedic surgeon not experienced, get a neurosurgeon involved, and make sure you have help. Somebody is there with you, because you don't want to go back and put a stitch and come out and end up with more leaks. This always happens, or most of the times I've seen this happen. You think the second time you've gone and done something like put a tissue or put a stitch, and then you come out because CSF leaks are really crazy. Technical pearls: put a patty, position the patient, get a safe sucker, reduce your suction pressure, use cottonoids, optimize the defect, get a microscope, get all micro instruments, get an assistant. The minute you get a CSF leak when you're doing surgery, and if you're doing alone with a nurse who's not experienced, call in your junior, call in a senior, or get some help. Always have these two instruments which are very handy. Nice sharp scissors, so you can use these to prevent CSF leaks. There's no really special consideration for during through tubes, very nicely demonstrated by Dr. Puneet. You can still get a dural tear and you can still repair it through a tube. So when not to suture. So if the breach is very small and if there's only a tiny arachnoid, you can take a risk and you can wait. You can give Valsalva maneuver, and if it is not leaking, you can take a risk and leave it, if you're not confident. If the procedure is an MIS and it's a very, very small, less than 1 millimeter, you can probably leave it. Or if it is very inaccessible at the axilla or the root, then you can probably wait. Just going to show you a few quick videos. Some of my cases. This is an over-the-top decompression. I've already had a CSF leak when I was decompressing the ipsilateral side. Sorry, the contralateral side. So I'm decompressing now the other side, and I immediately had a CSF leak. And the most important thing is, if you have a CSF leak, you should not stop your surgery. Because if you stop your surgery, then you're defeating the whole purpose of your decompression. So you can still repair something right on the opposite side. So this is something on the extreme lateral. I've tilted the patient by almost about 30, 40 degrees. I've tilted the microscope. I'm looking at the opposite side and I'm repairing the dura. You can see how slack the dura is. An elderly patient, 86-year-old patient who had an CSF leak, and it is still possible for you to go ahead on the opposite side and still put sutures. You just need to know how to handle your needle. You have a reverse needle, and you can take multiple small bites because it's not possible to do a continuous at that extreme corner of the side. So you can see that the ipsilateral side is good. I've done a complete decompression. So I've put my patties. So this happened at the initial part of the surgery itself when I was doing. So I just put patties and I completed the decompression, and I'm finally just doing a repair. And then you achieve very good hemostasis and a good CSF leak management. So this next one is another patient where there was a dural tear, and the tear was so haphazard, we were not able to actually close the dura. So and this was in a patient, in a young patient, and there was a bony spike which happened. One of my juniors started doing this, and I joined in, and by the time we got to this, we were not able to repair. So you can use various patches, you can use fat grafts, and you can still repair this. So I can just show you a few points here and there So that is how you put a synthetic graft and you put a fat graft around it, and you can still repair. So these are cases where you're not happy that the dura is adequate, and during the dural tear, a part of the dura also came with the bone. So you have to use a patch of this kind, and repair it. So, however bad a dural tear is, it can be, in my opinion, 100% repaired. So you need to get that confidence, and for that you just need experience. So you use a 6-0 proline, you can use interrupted, you can use muscle graft, and then followed by that you can use dural substitute, TCL, TacoSeal, and various other things. Wound drains. Again, people have different opinions about putting in a drain in different planes, in subcutaneous plane, or deep plane. So really it's a choice of the surgeon where you trained. But just looking at the literature, drain was used in some series, no drain was used in other series, and variable. So really there is no consensus in what's right. Definitely a good Valsalva maneuver is required. Just the last few slides about avoiding dural tears. As I said, watch for these ligaments. Be very, very careful with the instruments that you use. The disc punch, a high speeding burr. Your hand should be under control, whether you use a burr or use a punch. Always use two hands. However confident you are, however experienced you are, try not to use a sucker in one hand, and your upcut in the other hand. The easiest ones to repair are the A and B, which is the medial and mediolateral. The root sleeve is very difficult. So all the other techniques which I showed you can use. You can have a nerve hook, which is very good to prevent a dural tear. So you're adequately decompressing. And avoiding is, anchoring your hand, get sure you stay on bone, work in such a way that you don't slip. The surgeon should always use the pedal, in my opinion. Don't allow somebody else to press the pedal while you're using the burr. Have good magnification and good light source. Use a patty to protect the dura. So every step when it's tight, push a dura underneath and then do the decompression above it. Beware of anatomical variants. If you find that there's a dual root, so any of these things you're suspicious, be very careful. And the worst case, so this is actually a patient where it's actually the thoracic spine. It's thoracolumbar spine, and it is not for a lumbar canal stenosis. It was for a calcified disc. So after removing the disc, we'd actually put in TCL and we put in a patch and close, but the patient later on continued to have a CSF leak. And here we're using a technique called as a sandwich technique, which we've published this, where I'm using something called TacoSeal. It's currently not available in India. So there are two surfaces to the TacoSeal. There's one surface which is sticky and one is not. So you place them on opposite sides. It's like a plaster across the dura. And so that's what. So I put the TacoSeal on one side, and then you can use then TCL, and then the TacoSeal comes from the other side of the dura. So it sticks together, and it's like putting a plaster on the dura. And this works for extreme cases. So I'm just trying to say that any dural leak can be repaired. Sometimes they are very challenging. Very rarely you get caught up with such situations. So a dural tear should not stop you from doing complex cases, severe stenosis, calcified, whether it's an ossified ligamentum flavum or an large synovial cyst. It should not really stop you from doing them. So suturing, if it is primary, as much as possible, plus or minus a fibrin glue. If you're not suturing, you put in a patch, and then you put some fibrin glue and a lumbar drain. If you think that you can't suture it, it's so tiny, it's very difficult. Always do a Valsalva maneuver at the end to make sure that your closure is adequate. Watertight closure of subcutaneous and fascia is very important. Especially when you have a dural tear, make sure you do a double-breasted or a double-layered fascial closure, because if you can contain the CSF within the fascia and the wound heals, you can develop a pseudomeningocele. Not all pseudomeningoceles needs repair, and you can get away with just a CSF leak. No drain in my. These are my preferences. Some people would differ. So I don't use a drain. I don't use any antibiotics. I don't put them in prone. I don't give them, like strict bed rest 24/7. But I use antiemetic stool softeners. So thank you very much.
Thank you, Dr. Balamurli. We'll have a quick 10 minutes because already we are overshot the time. Quick 10 minutes question answer session. and the questions already in the Q&A box. I'll just take it one by one. So there's a question by Dr. Adhuri from Chandigarh. Any role of indirect decompression? Dr. Puneet, can you take up that question?
Indirect decompression for lumbar canal stenosis
Yes.
means like an OLIF procedure for,
Maybe that is what I think
or
he
something
Question
like
is
an
not very relevant, I think.
or
Question
interspinous device. Like these are things like they have not stood the test of time. The interspinous devices or interlaminar devices, some of them were used, but I think they have not become very popular just because of the fact that the indications were very difficult to identify the correct patients and the outcomes were very variable. So, as far as our science is concerned, direct decompression, either by open techniques or minimal invasive techniques, have more reproducible and more predictable outcomes.
Okay.
both the interspinous devices, the diam and the X-top, are not being used now. We did use lot of diams and we did remove lot of diams. So that was only one way of indirect decompression in a lumbar canal stenosis.
Okay. So, Dr. Ankur, I think you can take up this question. Are there any clear markers for surgical and non-surgical treatment in lumbar canal stenosis? Maybe it's an absolute indication you might have to just mention. Dr. Ankur, if he's not there, Dr. Rupinder, can you just...
Ankur, are you there?
Yes, yes. Are you asking
Yeah, yeah.
me? Oh,
So
okay,
yeah,
sorry.
I asked you, is there any
Okay,
clear
so
cut
I think there was some
marker
voice
that
break,
means
so I'll miss
indication?
the name. Anyway, I think, see, we have to be very clear in our minds that, there are certain absolute indications for surgery when we're dealing with lumbar canal stenosis. And they're also called maybe probably as red flags. First is any motor deficit which is significant. So, it's something like if let's say a patient is developing a weakness in dorsiflexion of ankle in an L4-5 stenosis, which means an incomplete or a complete foot drop, or a patient who has developed an S1 weakness with an L5 S1 stenosis. So a matching weakness, matching neurological deficit. At the same time, the deficit, let's say the grade of deficit and the age of the patient and functionality of the patient matters a lot. So, so many times we see that the extensor hallucis longus, the great toe has got weak, but we know that functionally the EHL weakness is not so disabling. And these are the patients I wouldn't really offer surgery. So one is neurological deficits which are significant and are likely to affect the functionality of the patient and maybe progressive. Second is any bowel bladder involvement, which we call as cauda equina syndrome. These are absolute indications for surgery. However, when we go to the relative indications, when you have given a fair
I
trial
think
to
Ankur,
patients,
so he asked for clear cut indications. So I think
these are
we'll...
the clear-cut
Yeah.
indications. Yes,
So
these are
I think
clear-cut
we'll let go
indications.
the relative. Dr. Bibu, so I would put this question for you. What is the post-op management after laminectomy? So what do you advise your patients after laminectomy?
So if you're sure that after doing a laminectomy, you haven't violated the facet joints, you can immediately move, and the patient is stable, the segment is stable. Usually the patient can be mobilized within 24 hours and he can made me to walk. The only thing which I usually advise the patient is it takes little time for the soft tissue healing. So they can walk as much as they can, but prolonged sitting, bending, and twisting movements need to be avoided, and sitting at the lower surfaces so that because they have to put a lot of effort to get up. So these routine things needs to be avoided, and rest they can carry on their routine activities and gradually progress to their normal activities.
Okay, so I would say the best thing what you want to know is ultimately you can mobilize them the very next day and keep them on restricted activities. That is what he wants to say. So the next question I will answer whether we have any credit hours for this program. We are working on it, and we will get back to you by the next month program. Before that, we will be clear whether we'll be able to offer you any credit hours for this program. And the next question is Dr. Bala Murli. This for you. Is open surgery better than endoscopic surgery for lumbar canal stenosis?
I
Bala,
I don't think that you can say that as a general statement for every patient. I do majority of my patients through tubes, but when I have a severe stenosis, and even if the patient says that I want it through a tube, I refuse. I say that this cannot be adequately decompressed through a tube, and I go for an open surgery. Even if I have to lose the patient, some very severe stenosis where you can hardly have any space there. You cannot, however good you are, however experienced you are. I think an open surgery is far better, especially they are elderly and one shot you want to give, because even if you have a CSF leak, you can't repair through those tiny tubes. So no generalized statement. You can use MIS, you can use endoscopy, you can use open surgery, whichever works in your hands, whichever you feel that you can give the best results is what I would recommend.
Okay. And I would just want to answer one doubt here for all the delegates. The delegates from Nepal, Bangladesh, and Sri Lanka who have joined, I know you guys had some difficulty in joining because of you had to mention the state and the place. So I would say till the time we rectify that, you can put any city name or any state name, and you can just put your name and numbers. You will be able to log in. So that basically we I think the questions are over by this, and we if we have any comment from any of the faculties, otherwise I invite Dr. Bibu to give his vote of thanks.
Bala, one question, and thank you again from the Spine Society. Asymptomatic pseudo meningoceles muscle patient just complains that he has a bulge, nothing else. Would you aspirate, put some bandage, or do you do anything for that?
Just leave them alone.
And one for a personal thing, for immobilization. Do you take them off the bed, go to the bathroom, and or something like that? Is it because we've been very strict with them and foot
Yeah.
and elevation and all those things?
No, see, this is something, when I started training, I'm talking about nearly 15, 20 years ago, that was normal. We used to put them in prone, put them in bed rest, put antibiotics, but, things have evolved and changed, and there's a lot of evidence that's come up. It's just not only my personal experience. There's a lot of evidence to say that none of these things help. But yes, bed rest is one thing that I follow in the sense that I allow them to go to toilet. I allow them to mobilize, sit down for eating, not to strain or anything for up to about 2 weeks. But I don't put them in total bed rest that they have to do their toilet, eating, everything in bed.
Oh, thanks.
Great, great. Dr. Bibu.
Yeah, thank you, everyone. I thank all the speakers for their excellent contribution, beginning from Anuj and Tarun, covering the anatomy and the pathonomic of LCS, and Ankur and Guru giving the tips for the clinical evaluation and selection of patients for single level and multi-level lumbar canal stenosis, and an excellent video presentation by Puneet. And I thank my guest speaker Bala from Chennai, giving great insights for the repair of the dural, which we orthopedic surgeons are really scared of, but he had made it look very simple. I thank all the viewers from international viewers from Bangladesh, Sri Lanka, Korea, and Afghanistan, and all the national viewers. And last but not least, our sponsors, Rajiv and from Sun
Rajesh.
Pharma, for getting this, making it success. And I look forward all of you to join back on the third seminar next month.
Bibu, we missed Dr. Tarun.
No, I said Tarun.
Okay.
Yeah.
Great. So we'll have next session. That is again the second Wednesday of the April. That will be on again 9th of April. So we'll be having a session on
PIVD.
most common problem which we face day in and day out. That is on prolapsed intervertebral disc. and hope to see you all soon again. And I would request all of you to spread the word and make use of this session. Thank you.
Thank
Thank
you.
you, everyone.
Thank you, everybody.
Thank you, everyone.
Thanks a
Thank
lot.
Thank you. Thank you.
We can